Hi, Arthur.
Hello, Ingrid.
How are you?
I'm fine and wonderful to join you and all the other colleagues and friends there.
Yes. Listen, Arthur, why do I can find the lines I have to describe you besides you are the greatest andrologist ever in the face of the earth. That's what I can say. And if you can enlighten us, what is your current position? What is it that you do? I will truly appreciate. So we can hear directly from you.
It would be my delight to do so. So, I'm a professor of urology at Johns Hopkins Medical Institutions in Baltimore, Maryland.
That's it? What a
Well,
humble man. Hello, Arthur. Please, a
I
little
made
bit
it,
more.
well, a little bit more. I happen to be the treasurer for the International Society of Sexual Medicine. I'm very involved in a number of societies, including the board of directors for the American Urological Association. And I've just been able to, over the years, have the good fortune of being in good environments and have good collaborators, whereby I've been able to make great contributions to our field. And I'm just so humbled to be with you as I have joined this conference over the years, although this time, unfortunately, I have some conflicts and demands and cannot be there with you in person. But thank you for the opportunity.
Thank you. So you can start now, Arthur.
Okay, let me put the presentation up. Okay, is everybody seeing the presentation? I hope so. So again, it's my delight to join you, and I would like to speak about the topic of testosterone, the impact of testosterone on men's health, and I'd like to take the focus on prostate health and prostate cancer, particularly prostate cancer survivorship at this presentation. Briefly, some disclosures. Now, my intent here is to describe for you how we should understand and manage male hypogonadism, also known as testosterone deficiency, and really understand its highest relevance likely in the prostate cancer patient, this being a conference on men's health, androgens, andrology, and oncology. And I do want to discuss with you the goals, the implications of testosterone replacement therapy in the prostate cancer patient with testosterone deficiency, and then also to review some progress we're making with some investigational studies that I think are very germane to the prostate cancer treatment survivor who has symptomatic testosterone deficiency. So, by way of definitions, there are a number of terms that I guess encompass this concept of men having decreased testosterone. There are a variety of terms, they have a variety of connotations. I think testosterone deficiency probably is the smartest among the many definitions. And in terms of understanding this now, there is a crude prevalence of symptomatic androgen deficiency of about 5.6%. It is known to increase with age. And so some of the older men certainly will have a relative decrement in their testosterone levels. And I'm sure we're going to hear from other presenters during this meeting about testosterone, perhaps in a more generic sense. Now, we do know there are various domains related to hypogonadism or testosterone deficiency. This slide does make the point of all of the different impacts from physical functioning, cognitive functioning, the bodily symptoms, sleep function, sexual function, of course, whereby testosterone does have some impact. I tend to think about it in three main pillars: sexual functioning, the muscle and physical muscle mass, strength, physical functioning, as well as cognitive abilities. And so those typically are almost the three pillars of testosterone impact. But I would like to say that these symptoms are arguably more compelling in men after prostate cancer treatment, to the extent that this is a category of men who I think have a dramatic change in their testosterone, often with the impact of treatments for prostate cancer. We know that in terms of androgen deprivation therapy, but also as men get older now, we do know that there's a gradual decline in many with their testosterone function and production. And therefore, how does that make sense in the setting of prostate cancer management? Testosterone deficiency is associated with a whole host of not just signs and symptoms, but also implications. And this slide makes the point that there are a variety of ways in which testosterone deficiency can ultimately have impact on not just a sense of well-being, but also mortality. So we need to recognize that. And we do think of classical hypogonadism in terms of primary testicular failure and secondary testicular failure, also known as hypogonadotropic hypogonadism. And on the slide here, and I won't read through it, there are a variety of classic disease states that we think of that fit these two categories, either dysfunction at the testicular level or at the hormone axis at the hypothalamic and pituitary level. We do understand the condition of adult onset hypogonadism, which may be equally prevalent or more common as men get older. Just a common phenomenon here that's typically associated with secondary hypogonadism, that is a failure at the brain level, if you will, the central axis, a central component of the axis, in terms of abnormal or ineffective gonadotropin releasing hormone secretion, and thereby failure to increase luteinizing hormone. There also is some impact having to do with sexual hormone binding globulin, with decreases in the amount of bioavailable testosterone on the basis of having this increase in SHBG. So there may be some multilateral factors involved as well. So what constitutes the definition of testosterone deficiency? Well, many in the audience know that it's a matter here of understanding the signs and symptoms, but also having a biochemical measurement that is consistent with testosterone deficiency. And that typically, according to many guideline statements and society guidelines, is how we should be referencing testosterone deficiency. Certainly, there is some controversy surrounding this, some discussion as to where the cutoff may be in terms of biochemical measurement and whether there could be potential benefit for those who are borderline normal. But nonetheless, the typical discussion is signs, symptoms, and then biochemical testing. So what about replacement? Well, there are a variety of options. The testosterone hits the media and the news very commonly, almost as a fountain of youth, or some sort of cure-all for a variety of conditions. And they're certainly there with many advertisements, various kinds of consideration for supplements. But I think we should go back and understand what are the real goals for treatment. And the slide here makes the point that it can have impact in sexual functioning, psychological well-being, physical functioning, and even possibly having some role with regard to bone mass as well. There have been issues surrounding cardiovascular disease risk, and I think the evidence largely is in the favor of being favorable. And in that, epidemiologic studies will support that those with cardiovascular disease typically are testosterone deficient. That's another discussion. And again, that fits with the understanding about the ramifications of testosterone and replacement. What about contraindications? Well, there are a variety of considerations, and prostate cancer is right there up on the list. And I'm going to talk through the next few slides, just I think where we think we can stand with regard to prostate cancer considerations. Some of the other issues are listed on the slide, certainly concerning with regard to some potential risks of testosterone, but not shown here on the slide very well, or at least that we should understand that is hematologic risks in terms of excessive testosterone therapy that puts patients at risk for thromboembolism, stroke, and whatnot. So the variety of considerations that are pros and cons with therapy. Let's talk about prostate cancer risk with testosterone administration. Well, certainly there is the view, maybe in a superficial way, that testosterone could be a risk factor to have prostate cancer. Prostate gland relies on androgens. There has been concern that there is potentially a change in PSA and prostate size with testosterone replacement therapy. And with regard to managing prostate cancer, we would deduce that prostate cancer can be reduced by withdrawing testosterone. So therefore, testosterone may have a role there, although I think the understanding has to do with prostate cancer in a more advanced state and not really induction of prostate cancer. And then there's been evidence in experimental work with animals that testosterone may promote prostate cancer development. So you can see controversy does exist out there in various ways, with maybe some arguable points that could be made about the risk. But I guess questions should be presented here. Could androgen supplementation unmask or stimulate an indolent prostate cancer? That question may be answered here in a slide or two. And then what about considering the history of prostate cancer? Is there a contraindication to androgen supplementation? And I do have a few slides that make the point to answer that question as well. So in terms of supplementation, we do know that with testosterone replacement therapy, it is so that the prostate size and PSA level increases do not necessarily rise in a very abnormal way. Some studies have gone back and looked at this now. It seems to be consistent with untreated matched eugonadal individuals. And so really, I think we would refute the argument that testosterone supplement automatically accounts for these changes more than the normal individual. And then meta-analyses have also showed a non-significant trend or inconsistent effect towards prostate events. And again, some other studies here have really substantiated that argument, that really the evidence is not clear that testosterone therapy does have untoward effects. Now, what about the men with the androgen, again, testosterone deficiency? Adam is described here by Leonard Marks in his report here using his terms. And I won't read through this slide, but I think this just makes the point that he did do a very rigorous study going back now several years, in which he took a cohort of men, studied them very closely on testosterone therapy, followed their prostate health with biopsies. I did follow them with various markers, and basically found that there's no change in voiding symptoms, urine flow, PSA, or post-void residual. And at 6 months biopsy, prostate cancer was found in 4 men on placebo and 2 on testosterone therapy. Certainly no greater effect in men who were on the therapy. So again, even a more rigorous study here that would counter the idea that testosterone is adverse with regard to prostate cancer risk. There have been retrospective studies, and I list a few here. I won't walk through them, but just to say that retrospective studies have looked at the effect here. And the challenge, of course, with retrospective studies is what we all know, that they're not controlled studies, and there could be always potential for bias. And I think a lot of our literature does have a lot of retrospective studies that I think are informative, but at the same time, I think they do have that potential limitation. What about men who are high risk or have untreated prostate cancer? And again, there's some studies out there, and I won't read through the slide. Perhaps you can read it as you see it, that there are studies out there that have looked at these special categories of patients, and the risk appears to be minimal. Moving on now in terms of risk of prostate cancer events during TRT large trials. The Traverse trial is one that I will emphasize here, that was recently published with a lot of attention, and looked largely at vascular events, but also looked at efficacy, and certainly there was studies that had to do with the prostate cancer risk. And the bottom line here is that there's a low overall incidence of prostate cancer, both in testosterone and placebo groups. And there does not to be any significant difference in those who are on these different treatment groups or placebo treatment groups, according to these studies. And the reason for this is, I think, the evidence by some luminaries in our field, Dr. Morgan Thaler, Dr. Kara, who have really described the saturation model, that we understand that beyond a certain level of testosterone, there is no growth that is induced by testosterone therapy. And the reality is there may be a threshold by which the prostate will grow, but beyond that, we will not necessarily see any prostate cancer risk. Dr. Basine, a leader in our field, has described endocrine society guidelines, and essentially the idea here is that we can certainly go about treating patients, monitoring them, evaluating their response, and then be safe in our management. Again, for brevity, I will not walk through the slide, but in terms of objectives and monitoring, certainly monitor patients with regard to the testosterone effect, see whether they meet therapeutic goals, evaluate whether this concurs with testosterone measurements, and you may carefully go about monitoring the risk for prostate cancer as well, including DRE, digital rectal examination, PSA, as well as some other parameters that might be looked at. There have been some who've reported a variety of monitoring approaches in terms of looking at a PSA rise or a rate of rise. All of these, I think, are valid options by which, if changes occur, proceed with your workup. Again, you can see from prior studies that there is a risk of prostate cancer in men, even without testosterone therapy, a background rate. So nonetheless, we need to follow these patients closely and then react if there seems to be a threat of prostate cancer. There are a host of therapies out there, from injectables, oral therapies, transdermal therapies. This is shown in various textbooks, and they do have their potential for side effects that we all have to be cognizant of. I do want to take a moment to speak about a trial that I have been fortunate to be involved with at Johns Hopkins, working with Dr. Bassine's group up at Brigham and Women's in Boston, Massachusetts. First ever randomized controlled trial in which we have now recently completed and are looking to publish it and also publicize it and inform our colleagues about it. But the bottom line is we are looking at a variety of endpoints here, change from baseline to sexual activity, secondary outcomes as well having to do with sexual function, as well as safety outcomes. And essentially, we are finding that there does appear through this trial, the SPIRIT trial, that with a randomized controlled trial, that there is benefit and safety. And you'll be hearing more about this study soon to come. So I'm going to conclude here. I wanted to be brief. That assessing the role of testosterone in the development of prostate cancer, that there is no evidence that this is firm in terms of the potential risk. And normal levels of testosterone replacement do not seem to promote carcinogenesis. The assessment of prostate cancer development should continue in terms of potential risk, but this should be done along the lines of just monitoring all men for the risk of prostate cancer. The future, I think, looks bright in terms of taking the knowledge that we've had from smaller studies, retrospective studies, and now moving towards randomized controlled trials and maybe even larger randomized controlled trials. The one I spoke to you about, the SPIRIT trial, was more of a proof of purpose study that may lead to larger trials whereby we can study the effect more convincingly. And I think in terms of current practice, we should go about establishing a clear benefit of treatment in terms of assessing the potential for benefit for patients. Patients should be counseled, document, and consent your management of these patients. So I will close there, and I do thank you for your attention. And I do hope to connect with you in person soon, although I will join you at various phases of the conference coming forward from a distance. So thank you again, Ingrid. You're so wonderful. And thank you for giving me the opportunity to present. Thank you.
Pero el doctor Bud está ahí. Bud.
Yes.
Thank you so much. We truly appreciate, the effort you have put in this. I know you had a lot of commitments, but you never fell me down. So thank you so much, and a big applause to Bud.
Thank you all. Thank you all.